and the genius in the hospital. And if you are one of the medics who work in the acute or general medicine or medical department, so you will need to know how to clerk a patient, right? So if we start with the clerking sheet, how does it look like, right? So in any hospital, it's different, but it contains the same stuff, all right? And even on the IT systems or different systems, it is the same. It will contain the patient details, the name, the hospital number, the date of birth, and you can just put sticker there. And who is clerking, the date and time, name, and your grade and your specialty. The age of the patient, is it present to complain why the patient came in today? Is it fall? Is it chest pain? Is it coughing? All right. And again, you can put your names here. All right. And then you can put the present complaint history in this area and the post medical history. Let's say the patient has diabetes, hypertension, ischemic heart disease, uh, uh, congestive heart failure, cataract, dementia, put everything there. And there is comorbidities. The patient had cancer before, has a CVD, CKD, COPD, asthma, dementia, diabetes mellitus, heart failure. Is he alcoholic, anxiety, registered blind? Has he had a cardiac pacemaker, which one of the most important thing if you are requesting MRI? Epilepsy, have he had geriatric falls? If you go further down, so again, in every single page, you need to put the patient name and the hospital number. You will do a review on the full systems, on the respiratory, and the abdominal, on the urogenital, CNS, and CVS. Okay, these are all the symptoms, the major symptoms. You'll find it here. And of course, the drug history, you can put the drug, the dose, frequency, everywhere. So the patient taking Ramipril 2.5 milligram once daily, atorvastatin 40 milligram once daily. You will write it here because the pharmacist will come and review what did you write, and they will review the system, and they will review the documentation. Those are documentation from the patient notes. Social history is one of the major area for the medical doctors in the hospital, for the medics. Is the patient smoking? Is it a COPD? Is the patient drinking alcohol? Will he get some sort of withdrawal symptoms? Is he taking any illicit drugs? With whom the patient live? Is the patient live alone? Where does the patient live? Is he in a respite home? Is she or he in a care home? Is the patient live alone by himself? Can he go upstairs? Is he living in a house? Is he living in an apartment? How many carers the patient had? What about his patient mobility? Is he using Zimmer frame? Is he using crutches? Is he using nothing? Okay. Does anyone have the advanced directive? What are the history of falls? Does the patient has any falls before? Again, the patient name, and you will examine the patient. Blood pressure, heart rate, the weight, respiratory rate, the oxygen saturation, and the capillary refill time, which is crucial. And you can put the news score is 1, 2, 3, 10. GCS, Glasgow Coma Scale. How is the patient doing? Is it 15 over 15? And then the mental state of the patient. You can ask the patient directly while you are clerking him about the age, year, date of birth, time, address, and count backward from the 20 to 1, and when was the World War II has been done, and then you calculate the AMTS. The cardiovascular examination, you will put your hand on your fingers on the pulse to find if the character of the pulse Is the patient in AF? Get the JVB as well, and listen to his heart and define the peripheral pulses. Respiratory, again, you will listen to the patient chest. And if the patient is asthmatic, please do the peak flow test. Please do the peak flow test. And you will examine the abdomen. And if the patient has a bleeding, you need to do a PR. Do not get the patient to the ward without doing a PR. And the neurological examination, if the patient coming in a stroke, you need to do the neurological examination as well. Usually, all the patient in A&E, if they are coming to you, whatever the reason is, you will have ECG. So you need to put the ECG findings, especially if they are cardiac patient, and chest X-ray findings. Okay, and then the diagnosis. The problem is, so why you will admit this patient? Is it because the patient has AKI on top of CKD? Is the patient because of the patient had a fall? Is it a social admission? Is the patient had MI? Why you are admitting the patient? But here, possible or treat as ischemic heart disease, treat as AKI on top of CKD, suspected urinary tract infection, suspected lower respiratory tract infection. All right. And then you will put your plan, your investigation, what investigation you need to do, what medication you need to stop or need to hold, and what medication you need to start with, who puts the cannula, who takes the cultures, if it has been done. All right. And then you will review, take your name and sign your name, and that's it. There is a sepsis 6 pathway. You'll find it everywhere in the hospital. And if the patient has temperature more than 36 or more than 38, less than 36 or more than 38.3, if the respiratory rate is more than 20, if the patient is acutely altered the mental state, like he is delirious, or the heart rate is more than 90, so it's called sepsis. So the patient will need to go through a specific protocol, and we can discuss it later on when we come to it. All right, good. So now you did had a look on the Clerking sheet. Okay, quickly we will take a case, which is a very common case. Let me bring it up here. All right. Okay, so this patient, 86 years old lady. Can you see it? Can you see it, chap?
Yeah, yes.
Yeah. So this 86 years old lady presented with a fall. Let's make it bold. And a long lay on the floor over the night. This fall was unwitnessed. No one witnessed this fall. And she was found by the neighbors around 6 a.m. And the ambulance brought her in on examination. There was no signs of fracture. And she has a past medical history of hypertension, diabetes, AF, and she's taking a Bixaban for that, ischemic heart disease, dementia, and when we have a collateral history from the daughter, she mentioned that mom was confused, delirious over the past few days, and she was complaining of burning urination. We did the bloods, and it did show AKI on top of CKD, acute kidney injury on top of chronic kidney disease, and the CK was 3000. Wow. And the urine was, let's say the potassium was 6.1, and the urine was positive for or make it, don't make it 5, and the urine was positive for WBCs, and started treatment for AKI. They started on 2 liters of fluid in A&E, and they asking for medical review for admission under medics. Usually you will get this from an A&E SHO or ANP, or whoever the person who's showing the patient or sees the patient in A&E. So take a minute and think about it and think, what should you do? You can stop the video for 1 minute and think, what can you do about it? All right, good. So let's go back to the clerking sheet. You are the SHO, the junior. You're gonna go to see the patient. What you gonna do? This is the clerking sheet, and you will go through it in easy way. Okay. All right. Let's go back to our document. You did read this one on the A&E system, and now you're gonna clerk the patient. So tell me what you're gonna write. All right. So let's take it one by one. So I'll put my name and I will put some details that I gathered from the notes. Okay. So my name is Dr. Salama. I work as an SPR, and this is an A&E admission. A&E admission. Okay. And the date of the today, and the patient has AKI and the full long legs is my diagnosis, and she might have suspected UTI as well, with past medical history of hypertension, AF, diabetes, ischemic heart, TIA, and the cataract. Okay, if you remember, I will review this patient right now, and I will take the present complaint of the patient. So that's what I will write in easy way as well. Some people write to do more writing, which is more beneficial and more helpful for lots of the people who will see the patient after you. Please do that. Write as much information as you can gather. So I will put it. She was admitted with unwitnessed fall, long lay on the floor, urine was stingy, and she was delirious on admission. Daughter explained about the burning urination over the last few days and delirium, as well as she had two falls before but wasn't admitted to the hospitals. And then I will take some of the social history. She live alone. She has carers for times, and the daughter do the shopping for her, and no other family members around. Okay, there is something missed here, which is the resuscitation status. What is the resuscitation status for this patient? Is she for resuscitation? Is she had DNA CPR? We have no idea. So if we have no idea, you should ask the patient or ask the family, and they will let you know. Okay, so she is for resuscitation. Fair enough. I will have to see the patient now and do some examination according to the system that we are dealing with and take it from there. All right, let's see. So we did some investigation. Blood pressure was 100 over 80, pulse was 80, temperature was 36.7, CRT less than 2 seconds, GCS was 15. The GVB wasn't raised. What does this mean? So she is euvolemic, or maybe dehydrated. Yeah. Okay. So head and neck, no signs of trauma, pupils, pills, chest equal air entry, there is no added sounds. The abdomen is lax, no tenderness. And I examined the upper limb. I didn't found edema, no signs of cellulitis. All right. What infection come to the skin? Cellulitis. Normal range of movement and the lower limb, because she had a fall. I need to examine everything. The lower limb, there is no edema as well. Normal range of movement, and there is no hip tenderness. Why there is no hip tenderness? Because of the high risk of fracture. This is a very common case and came in every single day. All right. So if we discuss this patient in easy way, and I know you did think about it right now, so there is lots missing for this patient. Okay, where is the bloods? This is the first thing. What is the creatinine? What is the stage of AKI? All right. The patient had a fall and it was unwitnessed, and she is taking DWAC, blood thinner. Where is the CT head? Is there a bleeding there? Who knows? Okay. Have you had a look at ECG? Where is the ECG? They didn't do ECG. Okay. Where is the VBG? I need to know about the lactate, why they didn't do the VBG. So there is lots of stuff need to be done. All right. So let's go through the investigation and see what we can do to help this patient and to clerk him in a good way. So we will request the investigation now. We will need the bloods. We need the full blood count, UNAs, LFTs, CRP. We need a VBG as well. Yeah, to look for lactate. We will need ECG to look for the heart. The patient had a fall. What is the reason of the fall? Is it a mechanical fall? Is it a multifactorial fall? Who knows? We need lying, understanding, understanding blood pressure. As the patient has orthostatic hypotension, that's why she fall. We need the chest X-ray to rule out lower respiratory tract infection. We need to send MSEU to rule out urine infection. We need the CT head to rule out intracranial bleeding, right? So there is lots we need to do with this patient. We need ultrasound KUP. We need ultrasound kidney urine bladder to have a look why, if you remember why, to rule out hydronephrosis and the hydro. Yes. All right. So this is the investigation. Now we will need to put a plan. What what is the treatment plan for this patient? I have no idea what is the treatment plan, and this is my first time to come over. So I will go now to the CKS, the hospital or the clinical guidelines. I will open management of acute kidney injury and I will jump to the management part. I will jump to the management of acute kidney injury. I will have a quick look and see where I am. Okay. And then see how I will treat and how I will follow up this patient after treatment. Okay, on CKS or on my clinical guidelines. All right, and you will find the clinical guidelines. I'll send it over. So if we go back, so what or how can we treat this patient? So the patient we know had AKI, had a multifactorial fall or had a fall, and now we will admit this patient to treat him. The first thing we will do, we will hold the nephrotoxic. Oh, I do remember that I forget to take the medication history. What this patient take? So this patient take ramipril, furosemide, statin, apixaban, metformin, and quinine. So the first thing I will do is to hold the nephrotoxic. I will hold the nephrotoxic, which are the ramipril, yeah, furosemide, yeah, and the metformin as well. You will hold it because of lactic acidosis. Okay. And on discharge, consider resuming and GB to review it and to repeat the bloods after 2 weeks of starting. You are not stopping it, you are holding it. Okay. So you did assume that this patient has UTI and she is dehydrated. So I will start on sodium chloride 1 liter every 10 hours, every 8 hours, and we can discuss the fluid later on in details and why I will put it every 6 or every 8 or every 10 hours. All right. And I will do the input and output balance. I need to know is this patient is weeing or not? Is she bringing urine out or not? How much she drink? How much she give us? All right, and I will encourage the oral intake for all the patient with dementia. I will encourage the oral intake. According to the CRB and the other markers, I will consider what antibiotic should I go for, and according to the guidelines, your guidelines, the clinical guidelines, or the NICE guidelines. and I will hold the Bixaban. Why I will hold the Bixaban? Because I'm afraid of bleeding. So I will hold it till I have the CT result. I will review and repeat the bloods tomorrow on daily basis because the patient had AKI. I need to repeat it on daily basis to make sure that she is improving. I will refer the patient to the physiotherapist and the occupational therapist to help her at home. I know she is having a four carers, but again, she will need to be seen by the physiotherapist to help her to get back on her legs and go back home. This patient is for full resuscitation, and she had lots of comorbidities. If you remember, she had dementia, and she had hypertension, she had AF, diabetes, ischemic heart disease, TIAs, and she did had lots of falls before. All right, she had lots of fall. If she had TIA, we should ask about the stroke as well. All right, she had TIAs before. So do you think our discussion is sensible thing to do or not? Yes, yes, it is sensible thing to do. All right. So you will discuss the DNA CBR with the patient and with the patient family as well. And we called it now the respect for. Okay. And you will send the patient for care of elderly. She will be moved to the care of elderly. All right. So you did lots of stuff. You asked for lots of stuff, and as we mentioned before, it is a continuous care. So the consultant or the registrar or the SAS doctor will come and review the patient after you, and he will tell you to do something you should do. Chase the CT results and blood results and put it on the system for the night team if you are going home, or to hand over it to the guy who came after you to chase the results and to take action on this one. All right, we did finish the AKI. I did take a lot of time, really sorry about that, but this is one of the very common cases you will see in the medics, and how to clerk the patient, how to get the patient in, and how to examine the patient, and how to put the investigation and chase the results as well. Thank you very much.